are coming just to see her. But Dr. Patel is Assistant Professor of Medicine and Oncology at the Palo Alto Veterans Healthcare System. She's a medical thoracic oncologist at Stanford University and the VA. She obtained her MD and Master's in Public Health at UNC Chapel Hill and completed her internal medicine residency, fellowship in hematology and oncology, and Master's in Science and Health Services Research at Stanford. Dr. Patel's research involves evaluating systems level and social factors that influence disparities in cancer. Her expertise lies in designing, implementing, and evaluating new models of cancer care delivery with academic community and VA oncology practices aimed to improve patient experiences with care, clinical outcomes, and reduced unwanted healthcare utilization and health disparities. And I've had the pleasure of reading several of her papers. She is one of the members of the Stanford Cancer Institute's Population Sciences program. And it's very creative, very innovative work that she's doing. And it's a real pleasure that she is one of our members of our program. She has experience in linking large cancer registries to investigate modifiable etiologies for cancer disparities. And I will say that I first met Dr. Patel when I was interested in sex differences in lung cancer and reached out to Heather Wakely, who is our mutual colleague and a true expert in sex differences in lung cancer. And she trained Manali Patel to kind of follow in her footsteps, although Manali clearly took a different direction, and it's very exciting stuff. And I don't know if it's okay if we go ahead and start a little early. It would, I will leave that up to Manali, and she can maybe speak up and say if it's okay to go ahead of time. It would give you the freedom of being able to go go slower and not have to push it all into 20 minutes. But it does mean that some people might be coming in 5 minutes into your talk. So I'm seeing, I think I'm seeing her nodding that it's okay. So it's my great pleasure to stop sharing my screen and to let Dr. Patel take it away. You must be on mute because I can't hear you. Okay, well, so by the time we get this worked out, she might be there. Okay, we're not hearing you yet. She's working on her screen. We're all kind of new at the webinar world, and Tio has done an amazing job of getting us this far, but hopefully she's still trying to do that. So Tio will get her connected and we'll be able to share her screen soon. Again, for any of you who didn't get the morning session, we had a fantastic panel, and I see that Dr. Tan is still on the call. So we had a fantastic panel on cancer and sexual and gender minority patients or persons. I don't usually think of people as patients because I think of them as research participants or as just people. So Dr. Patel, are you about to do it?
I hope so. Can you hear me? I'm at my home at the VA, so it's a little bit tricky with the regulations here, but apologize. I thought the old landline would work. Can you hear me?
Yes, we can hear you.
Perfect.
And if she's too soft, just crank up your volume. We have control of these people. Okay.
So I believe, hopefully you can see the screen here. Are you able to see?
Yes.
Okay, perfect. Again, thank you so much, Marcia, for that wonderful introduction. You know, it's a real pleasure and honor to be here today. As you mentioned, this has largely been the work of Heather Wakely, and I have transformed it a little bit towards the end to talk a little bit about the directions that we've been taking, most of the disparities work, but really looking at different factors amongst sexes, but also race, ethnicities. So as many of you know, yes.
Sorry to jump.
Molly, you're not on the presentation mode. You're on.
Yeah, if you
you're
can
not on presentation mode.
Showing 2 slides at once right now. There you go.
There you go. And then just click on so it's the full screen. It's frustrating because we can all do it for you, but
the problem is that I'm at the VA and on a PC. So let's see if I can do full screen. I apologize. How about this? Nope.
Well, that's okay. It's, if you can't do it, then we can go with this. We'll just all know what you're going to say next.
How about now? Perfect. Maybe. Nope.
Still not there, but
Okay.
there you go. Oh, that was it.
Oh no. Okay. I apologize.
Okay, we had time.
How about now?
No, but you know, this is a good use of the 5 minutes that we had. So try whatever you did just before you came off the screen was perfect.
So this is the problem with doing it from the VA computer.
If anybody who can talk. So Jim, you're usually good at things like this. I see you, and maybe Andy's good too. Anyone who knows how to help her would be great.
I apologize.
It's all right. You weren't even due to start till 1:30. So for anyone who's tuning in because you specifically wanted to hear Dr. Manali Patel, we have already introduced her and we're just trying to get this on to the right show and tell mode here.
Okay.
It's probably better if you just go with the other mode that you could do. And
okay, are you able to see it?
yeah, we can see it. Click like we all can see what you're supposed to click, but we can't do it for you. The presenter mode at the bottom of the screen, at the bottom of your slide.
Is that it?
Okay, well, we're still there, but.
How about now? Let's see.
Yeah, if you just click that thing at the bottom, so it's like 3 bars over from the gray thing, go 1, 2, there, that is, click that one, right there, yep. Okay, so it's not working. Well, whatever you had is fine, and we'll just go with what you have. You could also just show it that way and we can make it larger.
Maybe
you could click it up so it was more than 75% maybe.
I should have brought my own computer. Let's see from the current slide.
So for those of you who are coming from outside of Stanford, you can see that not all Stanford people are completely tech savvy either. So.
And definitely not on a Dell computer, on a PC. Okay, well, the clinic computers are not working with me here.
Okay, so just show it that way. I think it works fine. Okay. We can all blow up our
apologize.
So Dr. Patel is going to speak on Are Women More at Risk, Sex-Based Disparities in Lung Cancer.
So as many of you know, this is the slide that demonstrates the annual cancer incidence in the United States. And unfortunately, despite the fact that in the United States, we have prostate and breast cancer being the most common causes of cancer, the expected incidence amongst women and male is the second most common. However, the concern is that it's the most likely to cause death. So the most cancer-related deaths in the United States, more deaths than breast, colon, and prostate cancers combined, are lung and bronchus cancer, with an expected 23% of males passing away, as well as 22% of females passing away in this current year. And while we've seen recent declines in mortality over the past decade, mostly amongst the men, which I'll show in a couple slides, we did see that the largest drop ever was most recently from 2016 to 2017, where we saw that the largest ever single year drop in 1 year was 2.2%. And many have thought or hypothesized that perhaps screening and better therapeutic options were the reasons as to why we could potentially see this particular drop in the past year. The risk factors for lung cancer largely are smoking. As many of you have heard the discussions earlier today, as well as this discussion will focus on some of the data behind smoking. 91% of lung cancers are caused by smoking amongst men, but what we see is already a discrepancy amongst those lung cancers that are diagnosed in women, with only 80% of those cancers being attributed to smoking. A very important factor, which I think often goes overlooked, are environmental factors that contribute. Secondhand smoke, we know, is very common, But radon exposure is extremely common and the second most common cause of lung cancer, as well as many of us in California are experiencing now on the West Coast is industrial pollution, but also pollution from particulate matter due to fires and other hazards are also responsible for lung cancer. And my hope is that we don't begin to see that number rising in terms of the attribution to lung cancer. We do know that radiation exposure, while rare, is also associated, but we do know that there are other exposures such as asbestos, silicosis, and talc, which are associated as well, but not attributed with a particular percentage. And obesity and genetic factors have also been linked. This shows the slide of the per capita cigarette consumption on the y-axis, year on the x-axis, and age-adjusted lung cancer death rates. And what you see here in the green line is cigarette consumption, and how when the first Surgeon General report came out in 1964, essentially the rates of decline of cigarette smoking followed. And what we've seen now are a mirroring of death rates amongst both men and women, with a difference in terms of how quickly men began to plateau. We know that with behavioral patterns, women began to smoke a little bit later, and so we're expecting that that plateau is going to occur, and actually has already occurred in the early 2000s, with a subsequent lag in the decline in cancer death rates amongst women. This study just came out in August of 2020 and shows that perhaps these declines in cancer are actually different between both men and women. So in the New England Journal of Medicine in August, they utilized this surveillance epidemiology and end results database, which is a large database that covers the cancer registries across many states in the United States, and is able to attribute both incidence as well as incidence-based mortality. And here on in the blue arm is the men, and in the red arm is the men for the observed incidence, as well as males with the observed incidence-based mortality, versus women, both incidence as well as incidence-based mortality. And what they've found is that there was a sharp decline in rates, as I've mentioned earlier, that we've seen a really dramatic decrease in incidence. And that has also led to a dramatic decrease in terms of incidence-based mortality. And their thoughts are that perhaps maybe it's really more linked to the development of targeted therapeutics as opposed to cigarettes. While cigarette smoking has helped to decline the incidence, perhaps what's leading some of the mortality benefit is the therapeutic options that are now available, with one of the targeted therapies for lung cancer, which was developed and approved in the United States in 2013, really leading to the rapid decline amongst lung cancer mortality. What you see for women is a similar story, but I want to call into question the slope here. You see rather a flat slope. And again, with the mortality, we also see a flatter slope than we do for men. And so I will bring this back up in a couple more slides, and especially towards the end of the talk, as to what I think may be driving some of these differences. In our group, and again, I wish that I could pull this up because the histologies are really important to look at. So one question that I had was, with histologies with lung cancer, we differentiate lung cancer into what it looks like under the microscope. So either it's a small cell or it's a non-small cell, very rudimentary. And then within the non-small cell lung cancers, we know that there are different histologies. So the different tissues look differently, and they also appear differently and act differently depending on what the histology may be in terms of the tumor type. And what we've seen here is that in looking at the American community survey data, as well as the California Cancer Registry and the US Census, we really wanted to evaluate back in 2017 what the declines have looked like over the pericentral areas, but then also link this to neighborhood socioeconomic status, as well as stratify by males and females. And what we found was that there's sharper declines in all the histologies amongst men versus women, both for the small cell lung cancer, as well as for many of the subtypes of the non-small cell lung cancer. But what we found, and we were one of the first to begin to describe this pattern, was that when you look at a specific subtype of non-small cell lung cancer, this type called adenocarcinoma, there's actually a different pattern appearing, especially in more contemporary times. So what we're seeing now from 2008 to 2012 is amongst all race ethnicities, we are seeing an uptick and a rise in adenocarcinoma amongst females. And this is across every racial and ethnic group. Now in 2018, a year after we presented this data, the question still was rising whether or not smoking is leading to these differences. And so what we found with Jamal's group out of the New England Journal of Medicine was that by each age cohort, what he did was his group really tried to parse out if we really think that the smoking patterns amongst individuals that were born before 1960s were different, but rather around 1960s, we're starting to see that the patterns of smoking are actually very equivalent. So those that were born around 1960, the patterns amongst men and women, and they showed this in several tables in this particular paper, is that there were really equivalent smoking patterns. So you would expect that if there were rises in incidence in lung cancer, that perhaps the question about smoking to blame is no longer a question. And so what they showed here was that by different age cohorts, 50 to 54-year-olds up at the top, down to 30 to 34-year-olds at the bottom, both men in the blue and women in the red, was that there are declines in incidence. However, for the earlier cohorts, so for younger patient populations, there's actually a reversal in incidence, as we've previously shown, that females actually began to reverse this trend of having a little bit of slightly more incidence than men. And this was also shown in previous cohorts as well. So the birth cohort was another question that they really wanted to get at in terms of asking about the smoking question. And again, we see here for the birth cohorts, if you're born after 1960s, the question about smoking really no longer is an issue to ask, because the cohorts and the differences that we're seeing can't really be explained by prevalence of smoking amongst women versus men. And they corroborated our findings in terms of looking at these histologies. So perhaps what could be driving this increased incidence amongst females perhaps is due to adenocarcinoma, where you see across the board, female, regardless of birth cohorts, women really do have a higher incidence of lung cancer by histology amongst this adenocarcinoma subtype. When you look at the questions by race ethnicity, which is an area that I am extremely interested in, what you see here is a very different pattern. So, and I want to call into view essentially the non-Hispanic white patient population as well as the Hispanic population, where there's a reversal of trends, a complete reversal of incidence amongst this younger cohort as compared to men, indicating that perhaps this differences, again, in smoking behaviors is really not the reason driving these differences in incidence. Now, one question that always comes up is lung cancer just a completely different disease amongst females versus males? And one of the earliest studies back in 1993 really shows that this potentially could be the problem. Female smokers are more at risk than male smokers. So if you look at females who have consumed at least 40-pack years as compared to males who have consumed the same amount, the odds ratio is almost 3 times what you would expect amongst males. And why that is really concerning. No one has really quite understood why perhaps this disease may look so differently amongst female smokers versus male smokers. And I think that question is still one that we have unresolved. What's interesting too is women just tend to do better than men even once they're diagnosed. So this also raises a question about the disease process amongst women. Here are survival trends again in the most recent data I could find in August of 2020 in the New England Journal of Medicine. The same study using the SEER database found that across all race ethnicities, when you look at women versus men, women tend to have a better survival trend. And this was shown by us as well with our group here at Stanford, looking at the question of could social support really play the difference in terms of survival amongst Hispanic patient populations. And what we were really questioning, and it was really was driven by anecdotes and what I was seeing in clinic, is that a lot of Hispanic patient populations would come in with other social support. And could this potentially be driving some of their survival? So while this is a busy slide, I want to call into into your view the US born versus the foreign born categories. And what we did were hierarchical models, where the first model was just adjusted for clinical and demographic factors. The second model was adjusted for treatment, and the third model was adjusted for what we call a social enclave. I have an anthropology background and was really interested in trying to understand for foreign-born individuals this concept of neighborhood social support. And so we used the census to help us with a variety of different census variables, including percent linguistic, percent foreign-born, and neighborhoods, and found that when you adjust for these neighborhoods that have a very high proportion of foreign-born and enclavity, despite being low socioeconomic status, you see a survival benefit with the overall mortality really reducing from the first model, both in men and in women, perhaps indicating that this concept of social support, at least for foreign-born Hispanics, perhaps may be playing a role. Now for women, this concept of living longer across all disease stages, so this was a study that looked at both stage 1 and stage 2, as well as stage 3 patients that were diagnosed up to stage 3 with lung cancer, and women in this 20,000 older adult cohort, despite the treatment category, lived longer. So this is the survival probability over time. And what you see is that women, when they're resected with stage 1 and earlier stages of disease, really have a survival benefit. When they are provided with radiation and chemotherapy, a survival benefit as compared to males. And when they are treated or even untreated, still a statistically significant survival benefit. This was also shown in one of Heather Wakely's trials, an ECOG trial that looked at randomizing individuals to 4 different chemotherapy options. And what they found here amongst 1,200 individuals that were diagnosed with more advanced stages of disease were that while the response rates to these 4 different chemotherapies were essentially the same across sexes, what you saw was really a difference in terms of survival. Again, women having a favorable survival as compared to men at 1, 2, and 3 years. What was interesting to me was that women actually had more toxicity across several different toxic categories, with the exception of the adverse events from a cardiac standpoint. And so what's interesting here is perhaps, was there more of an efficacy difference? That, you know, could the drug potentially be more likely to work given these higher toxic factors, indicating perhaps a biological difference? That is one theory as to why women have a better survival. But again, you know, there are other questions such as hormonal factors, as well as these undetermined factors such as social networks and social support, as well as social determinants of health, that may be playing a role. The bottom line conclusion for me was that these data really indicate the importance of looking at stratifying by sex in many of these randomized trials, which has typically been considered a male disease. Now it's becoming more and more of a women's disease. I want to draw attention to the Women's Health Initiative, because this really was one of the first studies, especially looking at the estrogen plus progestin clinical trial, the randomized study that looked at the global index as the primary outcome. And specifically thinking about the influence of lung cancer within this cohort. So the influence of this combined hormonal therapy versus placebo, while it wasn't statistically significant in terms of the incidence in favor of the placebo arm, what you do find is that there was an increased incidence with 96 versus 72 cases diagnosed with non-small cell lung cancer amongst the women that were randomized to the combined hormonal therapy. Now, again, as I mentioned, it wasn't statistically significant. There were differences. Where we do see those differences are in survival. So the individuals and the women that were randomized to the hormonal arm of the study had a worse survival, a hazard ratio of 1.59, 67 versus 39 deaths as compared to the women that were randomized to placebo. When you look at the characteristics by the randomized group, and this again argues that perhaps women have a very different characteristic of the disease when they are diagnosed, women in the hormonal therapy arm had more stages and higher proportion of distant disease as compared to the placebo arm, and a poorly differentiated disease, which also portends a worse prognosis. And so these findings led to this secondary finding, looking at estrogen alone, in this Women Health Initiative study, where the primary outcome again was global index. And here there was a different story. So here the cases of lung cancer in those that received estrogen versus the placebo group, really no difference in terms of hazard ratios, both in the cases or the deaths. So there was a difference here, indicating that perhaps progestin modulates this relationship between non-small cell lung cancer and estrogen. And so, you know, it really calls into question the relationship between hormonal therapy, but really which hormones are playing most of the role. Now, I want to talk about never smoker lung cancer. So as many of you may know, lung cancer is now changing into what we really considered a smoking related disease to now a non-smoking related disease. And in prior cohort studies, we really had very limited data, especially using cancer registry data, because smoking is not assessed, which is still shocking to me that our cancer registries, which really do a wonderful job of following patients, don't assess smoking. But there have been several cohorts that have looked at very detailed smoking histories. And what you find here in the incidence rates on the y-axis, broken down by females in the cohorts for which we did assess smoking history. Never smokers, of course, amongst females have higher rates, but you start to see this uptick in incidence amongst non-smokers and never smokers, both amongst males and females. And when you pull up and look at these incidence rates a little bit closer, it actually appears that the incidence rates in never smoking adults is higher amongst women versus men. And this is proven to be the case. In global estimates, 15% of lung cancers in men are in never smokers, whereas 53% of lung cancer that's diagnosed amongst women are never smokers. In Asia, this number is much higher. We see the same pattern of never smokers with lung cancer having better survival than those that are current and former smokers. And we also know that women who are never smokers have a better survival than those that are men that are never smokers. In the early 2000s, we started really investigating this concept of precision medicine and what could potentially be driving these lung cancers. And we started finding really fascinating information about these driver mutations. And I want to focus in on this driver mutation called EGFR, which is the epidermal growth factor receptor. The epidermal growth factor receptor is a receptor that allows the epidermal growth factor to bind to it. And this is an enzyme that essentially regulates cell growth. It regulates how fast the cell grows and also what it looks like, how widely differentiated it may be. And what's unique about this particular growth factor is it was the first targeted precision medicine, if you will, molecular alteration for which we had actual therapies that we could provide to try to inhibit this enzyme from developing. So there were three different inhibitors. There's one more that's added now that inhibits this tyrosine kinase enzyme. And what we found in unselected patients with non-small cell lung cancer were these interesting patterns of who had this particular EGFR receptor. And it mostly was amongst individuals that were from Eastern Asia as compared to the United States. Again, this histology of adenocarcinoma, mostly in women and mostly in non-smokers. For gefitinib, which is one of the targeted agents, it's really changed our way of treating patient populations. This has really sentinelly changed the way that even today in clinic, that I even evaluate patients with lung cancer as opposed to when I first started in lung cancer almost a decade ago. Gefitinib here, for people that have the EGFR mutation versus those that don't have this mutation, our standard chemotherapy has always been these two drugs called a platinum doublet. So it's a carboplatin and a paclitaxel. And these are really toxic drugs. However, what they looked at in this particular study, in the IPASS study, was this targeted agent gefitinib. And for those that have this mutation, dramatically different survival rates. For those that don't have the mutation, the standard should still be the standard, this carboplatin and paclitaxel. But this really led to us changing the way that we treat patient populations. What was interesting, if you look at one of the other targeted agents for this particular EGFR alteration, is the differences in response. So amongst females, there's a higher response, and a higher proportion of females really respond to this drug as compared to males. Again, those that have adenocarcinoma, which is that histology that seems to be more common in females, and if you don't smoke, really have a better response difference. And now, if you can imagine, our targeted differences and targetable driver mutations has really completely expanded in lung cancer. I think it's actually a success story from the treatment standpoint, because we have many different ways that we can treat our individuals and our patients with lung cancer that we didn't have before with much less toxicity. The concern with precision medicine, as many of you know, while it's really wonderful in terms of providing these success stories, it's not always equitably applied. And here is a key point, that precision medicine not only requires thinking about what you're going to do with the test, so you actually have to test the tumor to make sure that the tumor has these molecular drivers, but then you also have to make sure that the right drugs are delivered. And if there's any one step of this process missing, you can imagine that the disparities will increase. And especially for women, if these particular tests and guidelines are not provided, you can lose out on the opportunity to really improve outcomes from lung cancer. This was a study that we looked at specifically of a ROS1 fusion. So this is another targeted agent where we've seen that there's a molecular driver that causes this lung cancer amongst non-smoking females. But then we also see that there's a drug that can be provided. Guidelines are not always delivered for many of these women. So this was a study of 277 people with this ROS1, a particular driver mutation, that we polled across 18 countries globally. And we found that a third of the patients had to ask for the test, that the system failed them a third of the time. The doctor may have requested it, but a third of the time the test was only ordered because it was initiated by the patient. And while this test is recommended 100% for patients when they're diagnosed with lung cancer, in the United States, you only seeing be delivered 50% of the time. In the first line of therapy, we all recommend getting the targeted agent for this patient population, but many of the patients, an overwhelming almost 70% of patients, did not receive that guideline-based care. And again, this is across many different nations, but we did not have enough numbers to actually break it down in terms of the United States versus other countries. But we do see that there are many people globally that are not getting crizotinib in the first line. Since this study, we actually conducted the study with the ROS1ers. So many different patient-driven groups have really tried to advocate for ensuring that patients are involved in the research process as well as involved in these agents and making sure that patients are educated. We see one group called the ROS1ers. The other group is called the EGFR resistors, and they call themselves the ALKs, but individuals that have ALK-positive disease. And it's been really wonderful to work with these patient-driven groups because they're able to take this messaging, which I think Dr. Lenas' presentation really dramatically demonstrated, was you can take patient-facing educational materials and really help to advocate patients to be a driver of their own healthcare and their own lung cancer treatment. Now, in terms of lung cancer screening guidelines, which I can't end the talk without this, this has been, again, a public health story in terms of smoking cessation and reduction of smoking cessation, but also attaching lung cancer screening in a way that's low cost and very less likely to be as risky to patients. The guidelines are focused on individuals 50 to 80 years old who have a 20-pack year smoking history. All the data I've shown you today shows that many women are younger when they get lung cancer and many are not smoking. So this recent study just in Japan about a month ago showed that out of 12,000 people that they screened, both smokers and non-smokers, greater than 40 years of age. Again, they took 40 years of age. Almost over 72% were diagnosed with lung cancer and they did not meet this criteria. And in fact, the criteria was a little bit more stringent of 30-pack year history of smoking. Equity is really a policy issue. So if it's not accessible, you can't offer it. And while Medicare does offer it, again, only for patients that have Medicare insurance, that are insured by Medicare, who are this older patient population, Within Medicaid, who we know this is a particular payer that should be paying for these services, we see that while the majority of the Medicaid programs do provide and offer this as a service for coverage, there are 10 programs that don't, and probably in some of the states that we know that there are significant risks for lung cancer, both amongst the smoking and the non-smoking patient population. And there are 3 programs that have absolutely nothing available in terms of what they cover and what they don't. In terms of advocating for lung cancer, you know, federal funding has led to these dramatic improvements in terms of how we treat lung cancer. We need to advocate for ensuring that people continue to have quality and affordable health care, especially because lung cancer is a pre-existing condition and may lose coverage if we see some of the insurance and policy actions in place that may potentially reverse some of the important strides that we've made in terms of payment. Tobacco cessation is also extremely important, and policies that help to improve the cessation of smoking by higher cigarette taxes are also important, as well as reducing radon exposure, education, and dissemination. So lung cancer is really not a disease amongst men anymore. We're seeing that it's really becoming more and more of a disease amongst women. Smoking is not really explaining this increased risk because more never smokers with lung cancer are women. Hormone therapy may lead to more aggressive cancers, and while driver mutations are really changing our understanding of how we treat and think about lung cancer, it has to be applied equitably. And I really argue that we should think about reframing our guidelines based off of recommendations on risk. Otherwise, we're worried that we're going to start to see more disparities amongst women with lung cancer. And I'll stop there.